Now we're going to get started talking about social and behavioral aspects of public health and what we mean. We're going to start with basic terminology. You're going to hear a lot of different terms through our readings and the videos that you're going to be exposed to in this course. So in brief, I want to begin to introduce you to terms that are important, and if you come across anything and need clarification, feel free to reach out to me. Epidemiology is the study of the distribution and determinants of diseases and injuries in human populations. We talk of incidence and prevalence of certain disease conditions. Incidence measures new cases of a disease that develop in a population during a specific period of time. And prevalence is the proportion of individuals in a population with a disease at a specific point in time. Morbidity relates to the relative incidence of disease, and mortality is the proportion of deaths in a population. Other terms, etiology is the study of the causes and origins of disease, and SES is what we refer to for socioeconomic status. Other terms relate to design issues. When we read articles, we're going to learn about cross-sectional studies, which is also known as your prevalence study. It's a non-directional study or a picture, a single point in time, and that does not tell us anything about temporality or causality, so it is a very weak design. A case control study is also known as a case referent or retrospective study. It's a backward or non-directional design that compares a group of cases and one or more groups of non-cases, or often referred to as controls, with respect to a given study factor. So you can look at it as, if I want to know among individuals who have osteoporosis and whether or not they have been taking bisphosphonates for strengthening their bone health, I would find a group of individuals both with and without osteoporosis, and I would look backwards to see between the osteoporosis group and the control group who took more bisphosphonates and who has the greater bone density and other things. You would want to try to match your cases in terms of demographics on age, ethnicity, so that you're looking at a very similar sample. And then another design is a cohort study. It's also known as an incident study or prospective study, and this is where you pick identify a group of people and you follow them forward over time to see if over time they get any conditions. And the twin studies that you might have heard of in Finland and in Europe, they follow a group based on the fact that they're twins to find out if they're similar in terms of disease progression or manifestation, especially among twins that might have been separated. All right, now let's get into what is a social determinant. This is a determinant of health that is very different than a biological factor. A social determinant affects many people in a population rather than just residing within one person. For example, a social network can be considered a social determinant. Social support is a psychosocial process that people engage in as a result of being in a network, which in turn can influence health. And we're going to look at examples of this idea applied. We need to think about what society does to affect the distribution of conditions or diseases. For example, what determinants in society affect hypertension, affect tobacco use, obesity, and so on? And while we can engage in activities to support physical activity and improve nutrition and giving up smoking, interventions often focus on just individuals themselves. We fail to look at the big societal determinants that are really weighing and perpetuating what's going on. So this entire class is dedicated to looking at activities that go beyond individual level interventions. Some examples of social determinants: religion, race, gender, ethnicity, class, socioeconomic status, income, education, occupation, social networks, as mentioned previously, integration, neighborhood, housing, crowding, marital status, retirement, job strain, work-life balance, effort-reward imbalances, family, transportation, food security, water safety, social isolation. This is just the beginning. What is missing from this list? I hope that you can help think through all of these. So one way that we can start to map out our understanding of these societal influences, these social determinants of health, is to create a figure that maps out social determinants to specific health outcomes. And in your Desire to Learn Brightspace materials, I have posted three manuscripts from scientists that have mapped out pathway models for specific social determinants. Adler and his colleagues look at SES and health, Ross, education and health, and Ellison and his group, religion and health. So in the Adler article, Adler actually outlines two different models that describe how SES is tied to or causes poor health outcomes. In the first model, it's simplified that SES described by education, income, and occupation. If you have minimal education, you're going to have a lower earning potential and income and get a lower ranked position. And these all in turn translate into health impacts. So how does Adler define education, income, and occupation? Education was occupational opportunities and earning potential. And in the population, what this translates to is an increased human capital, productivity. It's being able to socialize the next generation and decrease healthcare costs. So there's population level implications for education. In Adler also says for income that an individual can purchase better health care, nutrition, housing, and schooling when you have more income. And on a population level, the greater the income, you generate more income taxes, Social Security, welfare policies, earned income tax credits, and income inequality is reduced through Adler's eyes. And then on the occupational perspective, Adler noted that individuals with greater education and greater occupation opportunities have health benefits. They have a greater sense of identity, prestige, and job control. And in the population, what this looks like is increased profit, productivity, reduced absenteeism, reduced medical costs. It's being engaged in your job, which in turn actually benefits your greater community. The second model Adler proposes looks at SES but drills down even more specifically and now includes environmental exposures, the social environment, healthcare, behavior and lifestyle, and chronic stress as modifying factors on health. How are those defined? You can read those in the following slides. So environmental exposures consider toxic exposures, residential crowding and noise. Social environment looks at isolation, networks, cohesion, and capital. Healthcare looks at the uninsured access, Medicare, and Medicaid. So if you just want to consider it, think of Buckhead and think of Bankhead in Atlanta. You've got two polar opposite communities that could be explained if we applied Adler's model. You've got a community, Bankhead, that is in the same county, Fulton County, and it has dumping, it has toxic exposures, crowding, noise, environmental pollution. And how does that translate? There's environmental racism and injustice occurring. In the social environment, there's a geographical divide where in Buckhead, if someone has any sort of environmental issue, people can form together. They can have a sense of civil interaction and protest something coming into the neighborhood. And residents have much greater power to vote something down. And then in terms of healthcare, uninsured access quality, you're going to have people with greater benefits in Buckhead compared to Bankhead because of greater resources. The other two boxes in Adler's second model were behavior and lifestyle and chronic stress. So the characteristics for behavior and lifestyle were tobacco use, sedentary lifestyle, poorer diet. In communities with greater resources, you're going to have bike lanes, you're going to have lights on the sidewalks, you're going to have sidewalks. In terms of stress, you have lower employment rates and greater economic strain and more stress in Bankhead in a lower SES community. It's clustered. The third article by Ellison and Levin looks at health related to religion, and it illustrates the way religious involvement might actually be both positive or negative on populations in terms of health. Their modifying factors in the middle are individual lifestyle, health behaviors, social resources, positive self-perceptions, coping resources, and positive emotions, healthy beliefs, and some sort of really difficult to measure construct of healing or bioenergy. The reality is being religious or spiritual is clearly tied to health benefits. That is not debatable. There's an Office of Faith-Based Initiatives through the federal government. We know that it really does have a lot of positive benefits. So you can read through how religion might shape health because it discourages extreme behaviors. It can have restrictions on diet. But the internalization of religious norms and the way that particular lifestyle choices are viewed can be both positive and negative. In a church or in a religious group or community, you have a very tight-knit, dense social network. You can be integrated really easy if you are traveling to another country and your religion has outlets there and organizations of the same global network. You can walk into a church, whether it's here in Atlanta or in Africa, and you can relate to the pastoral advice. You can understand the norms and the practices and be at home, so to speak, even when you're away. Religion can shape positive self-perceptions through prayer, scripture, relationships, having this sense of divinity or something that transcends humanity, and then having fellowship and that support from people who have the same common beliefs. Religion can also offer coping resources, positive emotions, and healthy benefits, expecting the higher being to reward one's piety or worship, the sense of hope and positivity, optimism. But the problem is, it is very difficult to understand what is ethical in terms of putting on a public health research hat and trying to intervene in religions that might actually translate into negative health consequences. And does religion equal religious involvement? So a clear example of something in contemporary news is the female genital mutilation in Africa, and the controversy surrounding whether or not that religious practice is socially unjust, if people can perhaps modify that expectation, but it is truly very difficult. Now, on this slide, my notes are popping up here. I want you to look at the slide, and you can see that, well, what do you see? You see deaths per 1,000 from 1960 through 1986. You see at the very top, the greatest number of deaths are men with low education. And then it goes, the next highest group with for mortality is men with high education, followed by women with low education, and the lowest rates are women with high education. And so if I asked you to just stop for a second and think through, why are some of these reasons? This is the root cause analysis. Let's talk and dig deep and research what others have examined in terms of this relationship. We're now moving from the religion and health example, we're moving into education and health. So why would you speculate that among the low educated, both men and women, the subgroups, they would have higher rates of death compared to their counterparts with higher education? All right, let's move and see what Ross and Wu say in their pathway. Their pathway connects education and health. And they say work economic conditions, psychosocial resources, and health lifestyle are all influenced by education. And what do they mean by their moderating factors? Work economic conditions, that people with higher education are more likely to be employed, receive benefits. It determines your income, your degree of economic hardship, your sense of work fulfillment, your meaning of employment and a career, your level of job satisfaction. For social, psychological resources, the sense of personal control, that your belief and outcomes are contingent upon one's own choices and actions, social support, and being a part of a network. And the final modifying factor that Ross and Wu considered was health lifestyle, that the more educated you are, it determines the health behaviors that you're willing to take, such as exercise, smoking, and drinking. Now, here's another graph from Murawski and Ross, and they look at harsh or dangerous occupation over the level of education, and it is separated by males and females. And you can see that the greater the education, the lower, the harsher dangerous jobs are assumed. So with an elementary level education, both men and women have the highest rates of assuming harsher, dangerous occupations. This does have clear implications for health. So the problems or the questions that we have to consider in public health and in research are, what do we mean by education? Do we mean the number of years that you've gone to a formal school? Does it mean that you're competent in something? Does it mean that you have to earn extra credentials? There's many different ways to measure that. And so as we move along throughout this term, I am going to have you in your special topics presentation think of a social determinant of health and map out your conceptual model. Is it race? Does race relate to SES? Does SES, is it modified by anything in the explanatory variables? And what does that look like in terms of health? I want you to build your own. I'm going to give you project-specific guidance on Wednesday, the 8th, so look forward to that coming in Brightspace. But I want to close this session by saying, what good does it do to treat people's illnesses when we're only going to send them back to the conditions that made them sick? This is the heart of studying and dedicating attention to social determinants of health. We cannot pretend that health can be treated in a clinician's office without understanding the greater social context and fabric from which people come. And so thank you, and we'll keep moving forward.